imagine you're just walking into your laundry room, right?
Yep.
You open up a fresh container of laundry detergent, and suddenly you get this absolutely overwhelming, uncontrollable craving to eat it.
Which sounds completely wild.
It sounds like a psychiatric emergency, or, maybe craving the urge to just go outside, grab a handful of dirt, and chew on it.
Yeah.
It sounds absurd. But for literally millions of people, this is a very real neurological alarm bell that's just ringing in their brains. And it's all happening because they are missing this tiny microscopic amount of metal in their blood.
It's incredible.
So today, we are taking a custom-tailored journey into a physiological puzzle. And it's one that affects, get this, up to 1/3 of the entire global population.
1 in 3.
1 in 3 people. We are exploring the incredibly murky, sort of complex diagnostic waters of anemia.
It is, it really is a staggering statistic when you sit down and think about it.
Yeah.
Because 1 in 3 people on Earth are basically walking around with an internal supply chain that is fundamentally compromised.
Right.
And, the reason we call it a diagnostic puzzle in the medical field is because anemia, in the strictest clinical sense, isn't actually a standalone disease.
Wait, really? It's not a disease?
No, it's a symptom. It's essentially a massive flashing check engine light on your body's dashboard.
Yes.
It's telling you that some other, deeper system has just gone completely off the rails.
Okay, so our mission today is to help you, the listener, decode exactly what that warning light is trying to tell you. Because if you're just feeling tired all the time or constantly brain fogged, it isn't always just a lack of sleep.
Exactly. It's not just burning the candle at both ends.
Right. So we pulled a huge stack of comprehensive clinical guidelines for this deep dive. We're looking at data from Stat Pearls, the Mayo Clinic, the American Academy of Family Physicians, and some really detailed NHS protocols.
The gold standard stuff?
Yeah. And we're going to extract the most vital insights from all of them to help you understand your own bloodstream. Specifically, we're going to untangle the critical and I think deeply misunderstood differences between iron deficiency anemia and a completely different beast known as anemia of chronic disease.
And understanding that distinction is, well, it's everything. Because the way your body's malfunctioning, those two very specific scenarios, is entirely different. Even though, the fatigue feels exactly the same to the person actually experiencing it.
Wow. Okay.
Yeah, so my goal today is to explain not just what anemia is, but the underlying mechanisms, like why the human body sometimes alters its own functions, even seemingly working against itself when it's faced with different biological threats.
So whether you are prepping for your own upcoming doctor's appointment, or maybe you're trying to advocate for your aging parents who just keep complaining of relentless fatigue, or even if you're just managing your child's diet and want to set up their neurological development for success, this deep dive is designed specifically for you.
We want to give you the ultimate shortcut.
Exactly, the ultimate shortcut to being highly informed. So let's just start with the absolute basics to build a foundation here. When that dashboard warning light comes on, what is biologically happening in the body to trigger it?
Right. So at its core, anemia is defined as a significant reduction in your red blood cell count, your hematocrit, or your hemoglobin levels.
Well, hemoglobin, that's the big one.
Hemoglobin is the absolute star of the show here. It's this incredibly complex iron-rich protein that lives inside your red blood cells.
Ooh.
And its singular job, its entire purpose, is to grab onto oxygen molecules when the blood passes through your lungs.
Like a sponge.
Kind of, yeah. It holds them really tightly, and then it carries them through the circulatory system to drop them off at your tissues. When your tissues don't receive that oxygen, they enter a state called tissue hypoxia.
And that hypoxia is what physically causes those classic symptoms we all associate with anemia, right? Like the lethargy, the weakness, feeling totally winded after climbing one flight of stairs.
Exactly. Your cells are literally starving for the oxygen they need to create cellular energy, what we call ATP.
Right, ATP.
So your muscles fatigue faster, your brain struggles to maintain focus, which is the brain fog you mentioned, and your cardiovascular system just has to work incredibly hard to compensate for the thinness of the blood.
So when we talk about this alarm bell ringing, what is the actual threshold? Because I'm assuming the clinical guidelines have a very specific point where a doctor looks at the lab work and says, okay, yep, we have a problem.
They do, though. The normal hemoglobin cutoffs actually differ depending on quite a few demographic factors.
Oh, really? It's not just one number for everyone?
No, not at all. Generally speaking, the medical community looks for a range of 13.5 to 18 otograms per deciliter in adult men.
Okay. 13.5 to 18.
Right. For adult women, it's slightly lower, ranging from 12.0 to 15.0, and for children it kind of hovers between 11.0 and 16.0, depending on their exact age.
Got it.
But pregnancy shifts these target metrics completely.
Because of the blood volume.
Yes. A mother's total blood volume expands so dramatically to support the fetus. It's essentially diluting the blood. So the threshold for anemia in pregnancy drops to anything below 11.0 or even 10.0 depending on the specific trimester.
Wow, so the blood literally just gets watered down.
That's a great way to put it, yeah.
I'm really curious about the body's internal quality control here, though. Like, if my hemoglobin drops below those numbers, how does the body actually know? What organ is sitting there counting the oxygen delivery?
Oh, this is a fascinating biological design. The primary oxygen sensors in the human body are actually the kidneys.
The kidneys, not the heart or the lungs.
Nope, the kidneys. They filter massive amounts of blood constantly, and within the kidneys there are these highly specialized cells that act as like little oxygen meters. When the blood flowing through them has a low partial pressure of oxygen, meaning hypoxia, these cells undergo a chemical change.
Okay.
And that change causes them to synthesize and release a very specific hormone called erythropoietin.
Erythropoietin.
Yeah, but usually in medicine we just call it EPO.
EPO. Okay, anyone who followed the cycling schedules in the early 2000s will definitely recognize that acronym.
Lance Armstrong era, yeah.
Right. Athletes were illegally injecting synthetic EPO to supercharge their blood with oxygen and improve their endurance.
It's the exact same mechanism. The athletes were just artificially mimicking what your kidneys do naturally in a state of hypoxia. EPO acts as a powerful stimulator and messenger. So once the kidneys release it, the EPO travels through the bloodstream directly to your bone marrow.
Which is inside the bones.
Right, the spongy tissue inside your large bones, like your pelvis and your femurs. The bone marrow acts as the body's cellular manufacturing plant. So the EPO binds to receptors in the marrow and essentially shouts, the tissues are suffocating. We need a massive increase in red blood cell production immediately.
Okay, I want to build out a logistics analogy here to help visualize this because there are a lot of moving parts that can fail. Let's imagine the entire bloodstream as like a massive nationwide delivery network.
I like this. Okay.
So the red blood cells, they're the fleet of delivery trucks. The hemoglobin is the actual cargo space inside those trucks.
Yep.
The oxygen is the crucial package that needs to be delivered to the houses, the tissues. The bone marrow is the manufacturing factory that builds the delivery trucks. And the kidneys, using this EPO hormone, well, they act as the dispatcher sitting in a central office, monitoring the routes, realizing packages aren't arriving, and screaming at the factory to build more trucks.
That analogy maps perfectly onto the physiological reality. It perfectly encapsulates the entire erythropoietic cycle.
Okay, awesome. So if I'm the patient and I'm exhausted, meaning the delivery trucks are clearly not making it to my tissues, how does a doctor actually figure out where the supply chain is broken? Like, is it a factory problem, a dispatcher problem, or just a shortage of raw materials to build the trucks?
Right, and that is the fundamental detective work of a hematologist. The very first step in isolating the breakdown is looking at a specific metric on a blood test called the reticulocyte count.
Reticulocyte.
Yes. Reticulocytes are immature red blood cells. In your analogy, these are the brand new delivery trucks rolling straight off the factory assembly line before the paint is even dry.
Oh, okay. So they indicate current factory output.
Exactly. If a patient is severely anemic, but their reticulocyte count is very high, what we call a hyperproliferative state, it tells the doctor that the bone marrow factory is working overtime.
Right. The dispatcher's screaming, the factory is churning out trucks at maximum capacity, but somehow the overall number of trucks on the road is still low.
Yes, which implies the trucks are either being destroyed on the highway or, there's a bridge out and they're all falling into a river. In medical terms, the patient is either actively bleeding somewhere or their body is prematurely destroying its own blood cells.
Destroying its own cells.
Yeah, a condition called hemolysis.
Oh, you see this vividly in conditions like sickle cell anemia, right? Where the red blood cells become physically stiff and crescent-shaped. They break down in the blood vessels long before their normal 120-day lifespan is up, and the bone marrow is just frantically trying to replace them.
That is a textbook hyperproliferative scenario. Exactly.
Yeah.
But if we look at the lab results and the reticulocyte count is abnormally low, typically less than 2% in the presence of anemia, we're looking at a hypoproliferative state.
Hypo, meaning low.
Right. And this is a massive diagnostic clue. It tells the doctor that the factory itself is offline. The marrow is simply not producing new cells.
Which means what?
Well, it could mean the factory isn't getting the EPO order from the dispatcher, maybe because of kidney disease,
Hmm.
or, much more commonly, the factory just lacks the physical raw materials required to build the trucks in the first place.
And that brings us to the most common raw material shortage in the world, which is iron deficiency anemia, or IDA.
Yes, I do.
According to the sources, this represents the vast majority of anemia cases globally. It happens when the body simply lacks the elemental iron necessary to construct that critical hemoglobin molecule. No iron means no cargo space in the truck.
Right.
But when I was reading through the clinical guidelines for this deep dive, something really stood out. I think most people assume that if they are iron deficient, it's just because they aren't eating enough spinach or steak, like it's a diet problem. But the medical consensus emphasizes that in developed nations, it goes way, way beyond a bad diet.
It's a really critical misconception. While nutritional deficiency is definitely a major factor in developing nations, or, for individuals on very strict, poorly planned vegan diets, the clinical rule of thumb in adult populations in developed healthcare systems is quite different.
How so?
Iron deficiency is almost always viewed as a symptom of blood loss until proven otherwise.
Blood loss.
Yes. And we're rarely talking about an obvious major trauma like a car accident. We're talking about chronic, silent, slow blood loss.
Right. Heavy menstrual periods are obviously a massive and well-known driver for women of childbearing age. The monthly loss of iron-rich blood simply outpaces what they can absorb from their daily diet.
Absolutely.
But then the guidelines point heavily to the gastrointestinal tract. The GI bleeds. And this is the part that feels a bit unnerving to me. You could be losing blood every single day and have absolutely no idea.
It happens constantly. A patient could have a slow-bleeding peptic ulcer in their stomach, or colon polyps, or even early-stage colorectal cancer. These lesions can weep tiny, tiny amounts of blood into the digestive tract over months or even years.
And you just don't notice it.
No, the patient doesn't see obvious blood in the toilet, but their ion stores are steadily draining away day by day. Another huge, often overlooked culprit is the regular use of NSAIDs.
Non-steroidal anti-inflammatory drugs. Things like aspirin, ibuprofen, naproxen, basically the stuff people take every single day for a bad knee or a headache.
Yes. The mechanism of action for NSAIDs involves inhibiting an enzyme called cyclooxygenase, or COX. Now, while this is great because it reduces inflammation and pain, that exact same enzyme is responsible for producing the protective mucosal lining of your stomach.
Oh, wow.
So chronic NSAID use actively thins that protective barrier, making the stomach lining highly vulnerable to your own stomach acid.
Which causes the bleeding.
Exactly. It causes chronic microscopic bleeding. You're literally leaking your iron stores into your own digestive tract day after day, pill after pill.
Okay, but what about the scenario where a patient is definitely eating enough iron-rich foods and extensive testing shows they absolutely aren't bleeding anywhere, but they still have severe iron deficiency anemia? How is that physically possible?
That points directly to an absorptive issue. Going back to your logistics analogy, the raw materials are being delivered to the factory's loading dock, but the doors are permanently jammed shut. The human body absorbs dietary iron almost exclusively in a specific section of the small intestine called the duodenum. And the lining of the duodenum is covered in tiny, hair-like projections called villi, which basically maximize the surface area for nutrient absorption.
Like a shag carpet.
Yes, exactly like a shag carpet. But if a patient has an undiagnosed condition like celiac disease, their immune system reacts to dietary gluten by unleashing an inflammatory attack that literally blunts and destroys those villi.
It burns the carpet down.
Right. The physical real estate required to absorb the iron is just decimated.
And I imagine the same concept applies to patients who have had weight loss surgeries, like a gastric bypass.
Precisely. In a Roux-en-Y gastric bypass, the surgeon physically routes the digestive tract around the duodenum. The food and the iron it contains simply bypasses the very cells designed to absorb it. So the factory will starve for iron no matter how much spinach the patient eats.
Okay, so let's talk about what this extreme raw material shortage actually does to the human body. Because the clinical overviews outline some absolutely fascinating and frankly bizarre symptoms when iron deficiency anemia progresses from mild to severe.
They really are strange.
Yeah. If it's mild, you might be totally asymptomatic. You might just feel a little sluggish. But as the iron stores really empty out, the body starts exhibiting strained structural failures. For example, your nails can become incredibly brittle and literally spoon-shaped.
Koilonychia.
Koilonychia, right.
Yeah.
The guidelines say say your fingernails scoop inward to the point where they could actually hold a drop of water.
It is a really striking physical sign. See, the epithelial tissues of the human body, which include your nails, your skin, and the surface of your tongue, have an incredibly high rate of cellular turnover. They're constantly shedding and rebuilding. To maintain that rapid growth, they require a robust, oxygen-rich blood supply, sure, but they also require iron-dependent enzymes to form strong structural bonds. Keratin, which is the protein that makes up your nails, relies on these microscopic cellular processes. When iron is severely depleted, the structural integrity of those new cells simply fails. The nails grow out thin, weak, and concave.
And the tongue manifestation is also highlighted in the text's glossitis. The tongue becomes swollen, beefy red, and all the little bumps on it smooth out, making it incredibly sore to eat acidic or spicy foods.
Yes, the papillae just atrophy.
But I want to circle back to the hook we opened the show with, because the most mind-blowing symptom to me is pica, P-I-C-A. Both the Mayo Clinic and Stat Pearls heavily emphasize this phenomenon. It is the intense craving to eat non-nutritive, non-food items.
It is perhaps the most profound neurological manifestation of a simple nutritional deficit that we know of.
The sources mention people developing uncontrollable cravings to chew on ice, or eat dirt, or clay, or even developing unusual olfactory cravings like seeking out the smell of rubber tires or wanting to consume laundry detergents.
Yeah.
I really want to push back on the biology here and ask you to explain this because it seems completely counter-evolutionary. You lack a microscopic mineral in your blood iron, so your brain, arguably the most complex and sophisticated computer in the known universe, tells you to go to the laundry room and crave detergent. Or chew on a literal rock.
It sounds like a glitch.
It is a wild misfiring of the body's warning system. It's like your smoke detector going off, but instead of emitting a loud beep, it just plays smooth jazz. How does craving a rock help you find iron?
It's an entirely fair observation, and medically, the exact mechanism of pica remains an area of intense neurological research. It's not fully settled. However, we do have some really compelling biological theories.
Okay, let's hear them.
The brain relies on iron as a crucial cofactor for synthesizing neurotransmitters. Specifically, iron is required for the function of an enzyme called tyrosine hydroxylase, which is the rate-limiting step in producing dopamine.
Wait, dopamine?
Yes. When your brain is severely iron deficient, your dopamine pathways begin to malfunction.
And dopamine is the reward and craving neurotransmitter.
Exactly. This dopamine dysregulation is believed to be the root cause of these bizarre compulsions. It's not logical, it's chemical. It is also the exact same mechanism that causes restless leg syndrome, which is another major symptom of severe iron deficiency.
Oh, wow. I didn't realize they were connected.
They are. The patient gets an agonizing, uncontrollable urge to move their legs at night because the dopamine signaling in the brain's basal ganglia is faltering due to lack of iron.
That makes so much sense.
Regarding the specific cravings, though, the craving for ice, which has its own medical term, pathophysiology, is really interesting. One prominent theory suggests that chewing on hard ice triggers a vascular response called the mammalian dive reflex.
The dive reflex, like when you jump into cold water.
Exactly. Chewing the cold ice pushes more highly oxygenated blood up to the brain. It temporarily combats the extreme brain fog and fatigue caused by the anemia. So it's not that the body thinks the ice contains iron, it's that the body has figured out a mechanical hack to increase mental alertness.
That actually makes a bizarre kind of sense.
It does. But you are entirely right that the craving for dirt, or clagiophagia, is an evolutionary miswire. The brain recognizes a profound mineral deficit, dopamine pathways are misfiring, and it drives a compulsion toward the earth.
But dirt has iron in it, right?
It does, but the tragedy is that eating dirt won't effectively replace the highly bioavailable iron the body needs. In fact, in many environments, consuming soil introduces intestinal parasites like hookworm.
Oh, no.
And hookworms actively feed on the host's blood in the intestines, thereby making the iron deficiency even worse.
That is incredibly dark, but fascinating. The brain's check engine light is blinking, but the wiring is crossed.
Very crossed.
Okay, so that maps out iron deficiency anemia. The factory is missing the raw materials. But I want to explore the other major player in this diagnostic puzzle, which is anemia of chronic disease, or ACD. The NHS guidelines emphasize that this is the second most common type of anemia globally, and what makes this so critical to understand is that it is not about a lack of dietary iron at all.
Not even remotely. If iron deficiency anemia is a raw material shortage, Anemia of chronic disease is the sabotaged factory.
Sabotaged factory.
Also known in the literature as anemia of inflammation, this condition is driven by entirely different underlying systemic health issues. The fundamental architecture of the problem shifts from one of scarcity to one of active restriction.
So when we say chronic disease, what kind of conditions are we actually talking about here? What triggers this sabotage?
It encompasses any condition that keeps your immune system locked in a prolonged, unrelenting state of high alert.
Like autoimmune diseases.
Exactly. Autoimmune disorders are massive drivers. Diseases like systemic lupus or severe rheumatoid arthritis, where the body is attacking its own joints and tissues. But also inflammatory bowel diseases like Crohn's disease or ulcerative colitis. Chronic infections such as HIV, endocarditis, or tuberculosis, systemic cancers, chronic kidney disease.
That's a huge list.
It is. And even the low-grade generalized systemic inflammation that naturally occurs as the human body ages can trigger the onset of ACD.
So if a patient has a chronically inflamed knee from rheumatoid arthritis or an inflamed bowel from Crohn's, how does that localized inflammation somehow lead to a drop in the production of red blood cells in the bone marrow? What is the actual biological bridge connecting those two things?
To understand that, we have to look really closely at the immune system's cellular communication network. When your body's fighting a chronic disease, whether it's an autoimmune flare-up or an invading pathogen, your white blood cells release these tiny, highly potent signaling proteins called cytokines.
Cytokines. That term entered the public vocabulary heavily during the pandemic, usually in the context of cytokine storms causing severe lung damage. They're like the chemical alarm bells of the immune system.
That is a perfect description. They are the chemical messengers telling the entire body to marshal its resources and go to war. Specifically, a cytokine called interleukin-6, or IL-6, plays a starring role here.
IL-6, okay.
When IL-6 floods the bloodstream, it has profound cascading side effects on the body's iron metabolism. First, these cytokines travel to the kidneys and actively suppress the EPO dispatcher. So right away, less of the stimulating hormone is being produced.
The dispatcher is gagged.
Right. Second, they act directly on the bone marrow, blunting the factory's response to whatever EPO does manage to arrive, making the manufacturing process sluggish. Third, they alter the cellular membrane of existing red blood cells, causing immune cells called macrophages to just eat them, which shortens their lifespan.
It's a coordinated attack.
It really is. But the most crucial and arguably the most elegant thing these cytokines do is they cause the body to intentionally hide its own iron supply.
Wait, hide it. Why would it do that?
Well, to explain the why, we have to look at how the body stores iron. You have a protein called ferritin. Ferritin acts as a microscopic storage warehouse for iron inside your cells, primarily located in your liver and your immune cells. Under normal conditions, iron moves freely in and out of these warehouses as the bone marrow needs it for production.
Okay, the doors are open.
Right. But in anemia of chronic disease, the inflammatory cytokines, specifically IL-6, travel to the liver and trigger the production of a master regulator hormone called hepcidin.
Hepcidin. I saw this mentioned repeatedly in the more recent clinical updates.
Hepcidin is the ultimate iron gatekeeper. When hepcidin levels spike due to inflammation, it travels through the blood and binds to a protein called ferroportin. Yes, ferroportin is the physical exit door on the ferritin warehouses. When hepcidin binds to it, it destroys that exit door. The cytokines trigger a complete physiological lockdown. The iron is trapped inside the ferritin warehouses, locked deep in your liver and tissues, completely unavailable to the bloodstream or the bone marrow to make new red blood cells.
That is just deeply counterintuitive, if I can use our logistics analogy again to map this out. In iron deficiency anemia, the warehouse is empty. The supply ships never arrived at the port.
Yes.
But in anemia of chronic disease, the warehouse is completely full of iron. The parts are sitting right there, but the doors are heavily padlocked by your own immune system, and the bone marrow factory workers are just standing around the assembly line, unable to build the trucks because they can't access the supplies.
That is precisely the biological reality. The warehouse is overflowing, but the doors are padlocked shut by hepcidin.
So if I'm a patient sitting in a doctor's office, and I'm exhausted, pale, short of breath, how on earth does the doctor tell the difference? Because the physical symptoms overlap almost perfectly between an empty warehouse and a padlocked one. And this brings us to the detective work. How do hematologists differentiate these two using standard blood tests?
It requires looking far beyond just a basic hemoglobin check. The doctor must order a comprehensive iron panel to look at a very specific set of markers. The first major clue is found in the complete blood count. specifically the MCV, or mean corpuscular volume.
The MCV.
This metric simply measures the physical volume, the actual size, of your individual red blood cells, usually measured in femtoliters.
The size of the delivery tract.
Exactly. In iron deficiency anemia, the cells almost always present as microcytic. Micro meaning small, cytic meaning cell.
Why are they small, though?
The physiological reason for this is fascinating. As the precursor cell in the bone marrow is maturing, it is programmed to divide until it reaches a certain concentration of haemoglobin. Because there is a raw material shortage, no iron hemoglobin synthesis lags far behind.
Oh, I
So
see.
the cell just keeps dividing and dividing, waiting for enough hemoglobin to fill it up. As a result, the final red blood cells that get pushed out into the bloodstream are unusually small, typically less than 80 femtoliters.
Makes sense.
But in anemia of chronic disease, the cells are often normocytic. They are normal in size, usually between 80 and 100 femtoliters. The marrow is making properly sized trucks. There just aren't enough of them being made overall because of that suppressed factory response in the locked warehouse.
Okay, so cell size gives us a directional clue, but the clinical guidelines state that the absolute golden key to picking the lock between these two conditions is looking at that warehouse protein we mentioned, ferritin.
Yes. The ferritin level is the ultimate diagnostic differentiator because ferritin levels correlate directly with your body's total iron stores. If you have true iron deficiency anemia, your ferritin levels will be rock bottom because the liver warehouse is truly physically empty.
Right.
But if you have anemia of chronic disease, your ferritin levels will be perfectly normal or very often abnormally high.
High, even though the patient is profoundly anemic.
Yes, because the iron is trapped inside. The immune system's inflammation actually makes the liver produce more ferritin proteins to hold onto that iron even more tightly. Furthermore, ferritin is what we classify in medicine as an acute phase reactant.
Meaning what?
Whenever there is systemic inflammation anywhere in the body, ferritin levels naturally spike as part of the immune response.
All right, so ferritin tells us if the warehouse is full or empty. But just because the warehouse is full doesn't mean the delivery trucks are actually on the road. Is there a metric that shows us what's happening in transit?
Yes, that is where we look at transferrin. Transferrin is the transport ship of the bloodstream. It's the specific protein that binds to iron and ferries it through the blood to the bone marrow. By measuring total iron binding capacity, we can see what the body is trying to do.
Okay.
In iron deficiency anemia, the body is desperate. The liver synthesizes massive amounts of transferrin, sending out massive fleets of empty transport ships, hoping to find any stray iron molecules in the gut. So transfer levels are high.
It's casting a wide net.
Exactly. But in anemia of chronic disease, the body's goal is to keep iron locked away. The liver actively turns down the production of transferrin. The body doesn't want the iron moving around the bloodstream. So transferrin levels are typically low or normal.
So what does all this complex biochemistry mean for the actual patient? Let's say I get my blood test results back on my healthcare app, right? Before I even have the chance to sit down and talk to my doctor, I open the app and it just highlights low iron or low hemoglobin in bright red.
A very common scenario.
My immediate logical instinct is going to be to run to the pharmacy, buy an over-the-counter iron supplement, and start taking it every morning. But if I actually have anemia of chronic disease, not an empty warehouse, but a padlocked warehouse, will swallowing that iron pill even do anything?
This raises an incredibly critical point regarding patient safety. And the answer highlights the severe danger of self-diagnosing based on an app notification. If you have anemia of chronic disease, taking an oral iron supplement will likely do absolutely nothing to fix your anemia.
Nothing.
Nothing. The underlying inflammation is still raging. The hepcidin padlock is still firmly on the door of the enterocytes in your gut. Any new iron you ingest will either sit in your intestines causing severe distress, or it might get absorbed slightly and shoved straight into the locked liver warehouse.
So I'm just swallowing a heavy metal supplement for no reason?
It is actually much worse than no reason. The human body is a highly conserved system. Evolutionarily, iron was hard to come by, so we developed zero active biological mechanisms for excreting excess iron.
Wait, we can't get rid of it.
We can't pee it out, we don't sweat it out in any meaningful amounts. The only way we lose iron is by bleeding. If you continually take heavy iron supplements when your cellular stores are already full, which is the case in ACD, that iron has nowhere safe to go.
Oh, no.
The excess unbound iron can build up and begin to deposit in your major organs. It undergoes a chemical reaction called the Fenton reaction, which generates highly reactive free radicals. This causes severe oxidative stress, leading to a condition similar to hemochromatosis.
Which does what to the organs?
It can cause permanent irreversible scarring and damage to your liver. It can deposit in your heart muscle and cause arrhythmias, and it can damage your pancreas, leading to diabetes. You are literally poisoning your own organs trying to cure a symptom you misunderstood.
Let's just let that sink in for a second, because that is a massive, actionable takeaway for anyone listening. Taking iron pills when you do not actually have a true iron deficiency can permanently damage your internal organs. You need the doctor to run a full iron panel and check your ferritin, not just rely on a basic hemoglobin level.
Exactly. Don't guess. Test.
Okay, let's shift our focus to how this condition actually impacts different demographics. Because the physiological mechanics might be the same, but how this disease plays out depends heavily on who is experiencing it. The guidelines emphasize that age completely changes the risk profile. Let's start with the youngest among us, infants and young children.
Right.
The American Academy of Family Physicians notes that anemia affects roughly 269 million children globally. That is a staggering, heartbreaking number.
It represents a profound global health crisis,
Mm.
and the stakes for an infant are fundamentally different than for a 40-year-old adult. For an adult, severe anemia causes fatigue, cardiovascular strain, and poor quality of life. But for an infant whose brain is rapidly developing, iron is not just for carrying oxygen, it is a critical neuronutrient.
How does the infant brain use it differently?
The developing brain requires immense amounts of iron for myelination.
Myelination.
Myelin is the fatty insulating sheath that wraps around the nerve fibers, the axons in the brain and spinal cord. It is what allows electrical brain signals to travel at high speeds. The cells that produce this myelin, called oligodendrocytes, are highly iron dependent.
Okay.
If a baby is iron deficient during the first 2 years of life, the oligodendrocytes fail to function properly and the myelin simply doesn't form correctly.
So the electrical wiring of the brain is essentially left uninsulated. What does that mean for the child long term?
Severe untreated iron deficiency from a very young age leads to measurable impairments in cognitive function, delayed motor skill development, altered social interactions, and increased behavioral issues.
Wow.
And the most alarming part of the pediatric medical literature warns that these neurodevelopmental delays may not be fully reversible later in life. Even if you completely fix the anemia when the child is 4 or 5 years old, the critical developmental window for that early myelination has closed. The structural deficit is permanent.
That is terrifying for any parent listening. So what are the precise prevention strategies? The guidelines give very specific timelines and nutritional mandates for that first year of life to ensure this doesn't happen.
They do, and pediatricians monitor this very closely. The primary focus is entirely on the first 12 months. Whether a baby is provided breast milk or iron-fortified commercial formula is the starting point. But here's the crucial biological detail that many parents miss. While breast milk is widely considered the perfect food for an infant, its actual iron concentration is relatively low.
Really? I feel like that's not widely known.
It's true. Nature designed it this way because a full-term baby is born with a massive stockpile of natural iron stores, inherited directly from the mother during the 3rd trimester of pregnancy.
Right. But that stockpile isn't infinite. The Mayo Clinic source explicitly states that those maternal reserves run out at approximately 4 months of age, which means breastfed babies need an external iron source starting right at that 4-month mark, usually just a liquid supplement drop.
Precisely. If the baby is exclusively breastfed, they hit an iron cliff at 4 months. The pediatrician will prescribe liquid iron drops to bridge the gap, and then at the 6-month mark, when the baby's digestive tract is ready for solid foods, the guidelines mandate prioritizing iron-rich pureed meats or heavily iron-fortified infant cereals. The parents must actively step in and supply the raw materials for that rapidly growing brain.
And there is a major, heavily bolded warning in the pediatric guidelines regarding milk, specifically cow's milk. The advice is to severely limit it for toddlers, keeping it strictly under 24 ounces a day. Why is cow's milk so detrimental to a toddler's iron levels?
It acts as a multi-pronged threat to iron status for 2 main reasons. First, cow's milk is an incredibly poor dietary source of iron in its own right. If a toddler is drinking 30 or 40 ounces of milk a day, they are filling their tiny stomach capacity with a liquid that provides high calories but 0 iron.
They fill up on the wrong thing.
Exactly. They simply won't be hungry for actual iron-rich solid foods. It displaces the good nutrition. But the second, much more insidious reason comes down to intestinal biochemistry.
Oh, here we go.
The high concentration of calcium and casein proteins in cow's milk actively inhibits the absorption of what little dietary iron the child might actually be eating. Calcium and iron are both divalentations.
Meaning they share the same electrical charge.
Right, and they literally compete for the exact same cellular transport doors like DMT1 on the surface of the intestinal cells. Calcium usually wins that battle, blocking the iron out. Furthermore, excessive cow's milk introduced to a young, immature gut can cause an allergic-type reaction resulting in microscopic inflammation and bleeding in the intestines. The child is literally losing blood and iron directly into their stool.
So too much milk is displacing the iron-rich foods, chemically blocking the iron they do eat, and potentially bleeding out the iron stores they already have. That is a triple threat.
Yeah.
Parents, hear the guidelines clearly. Keep the cow's milk under 24 ounces a day for toddlers.
It is so important.
Let's jump to the entirely opposite end of the demographic spectrum. The elderly, specifically patients over age 65, the statistical prevalence of anemia jumps massively here, over 20% in the over 85 population, and staggering numbers, 50 to 60% in nursing home and assisted living populations, more than half.
It is incredibly, overwhelmingly common in older populations. But the clinical challenge here is one of perception. The symptoms of mild to moderate anemia, the chronic fatigue, the slight shortness of breath, the desire to rest more often, are very often dismissed by both the patient and their families as just a normal part of getting older.
Oh, of course.
Or they're clinically masked by a dozen other comorbidities. If a patient has arthritis, mild heart disease, and diabetes, the fatigue is just blamed on the obvious issues.
Right. If an 85-year-old says they are exceptionally tired after walking to the mailbox, people just nod sympathetically. They don't immediately think, we need a complete blood count right now. But the systemic manifestations of chronic anemia in older adults are deeply aggressive, aren't they?
Yes, because in older adults, the cardiovascular system has lost its youthful resilience. When the blood can't carry enough oxygen to the tissues, the brain signals the heart that it needs to pump faster and harder to compensate for the thinness of the blood.
It's working overtime.
And over months and years, this leads to a highly dangerous condition called high-output heart failure. The heart muscle literally wears itself out trying to circulate thin, oxygen-poor blood. This chronic strain exacerbates pre-existing angina, triggers dangerous arrhythmias like atrial fibrillation, and causes cardiac hypertrophy, where the left ventricle of the heart muscle thickens abnormally and eventually fails.
But beyond the devastating strain on the cardiovascular system, the clinical guidelines outline a massive flashing red flag for this specific demographic. If you are listening to this and you take away absolutely nothing else about the elderly and anemia, it must be this clinical rule drawn straight from the internal medicine protocols.
Yes, the GI rule.
Right. New onset iron deficiency anemia in anyone over the age of 55, and especially in men or postmenopausal women, must be investigated as potential gastrointestinal cancer until definitively proven otherwise.
It is a non-negotiable rule in internal medicine and gastroenterology. The logic is entirely physiological. Adult men and women who have passed menopause do not have any natural physiological reason to be losing blood.
Right. They don't menstruate, they aren't growing.
Exactly. Therefore, if a 60-year-old man suddenly presents with a completely empty iron warehouse, iron deficiency anemia, that iron is going somewhere. He is bleeding. And the most common, silent, and deadly place for an older adult to slowly bleed from is a malignancy, a tumor in the colon or the stomach.
So the anemia is essentially a proxy alarm for a tumor.
Exactly. Finding that unexplained anemia on a routine yearly blood test is very often the absolute first, and sometimes the only, early warning sign of colon cancer. A tumor in the colon is highly vascular. It creates its own messy network of blood vessels to feed itself. As stool passes by, these fragile blood vessels are scraped and bleed microscopic amounts into the bowel.
Wow, okay. That is incredibly stark. The takeaway is clear. If you or your parents are over 55 and suddenly diagnosed with iron deficiency out of nowhere, you must advocate for a colonoscopy and an endoscopy. Do not just let a doctor hand you an iron pill and send you on your way to ignore the root cause.
Never accept just an iron pill in that scenario. Push for the scope.
All right, we have mapped the mechanics, the tests, and the age risks. Let's move into the action plan. Let's say you've done the detective work with your doctor. You know exactly what kind of anemia you have. Let's talk dietary optimization, clinical management, and exactly what to ask your physician. If someone has mild iron deficiency anemia, how do they practically optimize their meals to refill that warehouse?
The dietary strategies are highly effective, but only if you understand the biochemistry of digestion. It's not just about eating a pile of high-iron foods. It's heavily dependent on what you eat together.
food pairings and chemistry.
Exactly. First, you must identify your iron sources. Heme iron comes exclusively from animal products: beef, poultry, liver, seafood. Because the iron is already bound within an animal's hemoglobin molecule, it is highly bioavailable. Your body absorbs it very easily.
Makes sense.
Non-heme iron, on the other hand, comes from plants: beans, lentils, dark leafy greens like spinach, dried fruits, and fortified cereals. This plant-based form is chemically much harder for the human gut to absorb.
Which explains why vegetarians and vegans have a statistically higher risk of developing IDA. So what's the scientific strategy to actually absorb that spinach better?
You must leverage vitamin C.
Vitamin C.
Yes, ascorbic acid acts as a molecular unlock key for non-heme iron. To get slightly technical, dietary plant iron exists in the ferric state, or F3 plus Su.
F3 plus C. Okay.
The intestinal cells can't easily absorb Fe3 plus pico. But when you introduce ascorbic acid, it chemically reduces the iron from that ferric state to a ferrous state, or F2 plus pico. This specific ferrous form fits perfectly into the DMT1 transport proteins on the surface of your intestinal cells.
So, practically speaking, what are some easy, everyday meal swaps for someone trying to boost their numbers?
It's about building habits. If you are eating a large spinach salad, don't drown it in a heavy cream-based dressing. Squeeze fresh lemon or orange juice over it. The citrus acid does the heavy lifting. Add diced tomatoes or brightly colored bell peppers to your lentil soup. If you're feeding your child an iron-fortified breakfast cereal, make sure they drink a small glass of orange juice with it, or put strawberries in the bowl. The simple addition of vitamin C can increase the intestinal absorption of that plant-based iron by 2 to 3 times.
That is such an easy, actionable swap. Just add a squeeze of citrus to your greens. But on the flip side of that biochemical coin, what should we be actively avoiding? What blocks absorption?
You must strictly avoid taking your iron supplements or eating your high-iron meals alongside calcium-rich dairy products like milk, yogurt, or cheese.
Right, the calcium competition we talked about.
Yes. Additionally, avoid drinking coffee and black tea with your meals. These beverages contain powerful plant compounds called polyphenols and tannins. These compounds bind fiercely to iron molecules in the acidic environment of your stomach, creating large, insoluble complexes that your body simply cannot absorb. They just pass right through your digestive tract.
So a spinach salad with lemon juice, yes. A spinach salad with a massive iced coffee and a chunk of cheddar cheese, hard no. What about medications?
The biggest culprits are antacids and proton pump inhibitors, like omeprazole. Iron requires a highly acidic stomach environment to dissolve properly and separate from food proteins. If you take a pill that actively neutralizes your stomach acid or shuts down acid production, the iron remains trapped in its complex form. The iron supplement just passes right through you into the toilet.
Now, what about clinical management? If dietary swaps aren't enough, doctors prescribe oral iron supplements, usually ferrous sulfate or ferrous fumarate. But patient compliance with these is notoriously terrible. Nobody likes taking these whole pills. The side effects are brutal.
They truly are. High-dose daily oral iron can cause severe constipation, intense nausea, cramping, a lingering metallic taste in the mouth, and it will undeniably turn your stools black and tarry. It causes massive compliance issues. Patients take it for a week, feel absolutely miserable, and simply throw the bottle in the trash.
But there has been a major shift in the clinical protocols for this, hasn't there? A way to mitigate those side effects while still absorbing the iron.
Yes. For decades, the standard medical advice was to tell patients to take an iron pill 3 times a day. But recent profound research into that padlock hormone we discussed earlier, hepcidin, changed everything about how we dose iron.
Oh, how so?
When you swallow a large dose of supplemental iron, your liver senses the massive influx and responds by intentionally spiking hepcidin levels to stop you from absorbing too much too fast and poisoning yourself. That hepcidin spike, that padlock on the gut, lasts for about 24 to 48 hours.
Oh, wow. So if I take a pill on Monday morning...
Your body locks the doors. If you obediently take another iron pill on Tuesday morning, your body's absorption doors are still completely locked from yesterday's dose. That Tuesday iron pill just sits uselessly in your gut, irritating your stomach lining, feeding the bad bacteria in your colon, causing severe constipation and nausea, and it isn't even absorbed. So the new, highly recommended clinical protocol is to take oral iron every other day.
Every other day. That goes against everything we naturally assume about daily vitamins.
Yes, Monday, Wednesday, Friday.
Ooh.
Taking it every other day allows those hepcidin levels to naturally drop and the door to unlock. Clinical trials have proven that patients absorb almost the exact same total amount of iron over a month using this alternating schedule, but with drastically reduced gastrointestinal side effects.
That is genuinely life-changing information for anyone currently struggling with the misery of daily iron supplements. But what happens if oral iron just isn't cutting it? Or the patient has a condition like celiac disease, where they physically lack the intestinal villi to absorb it regardless of how they dose it.
That is when the hematologist will escalate the treatment plan to intravenous iron, for iron, using formulations like Ferinject or Venofer. This involves sitting in an infusion clinic and having the iron drip directly into your vein, completely bypassing the damaged, inflamed, or stubborn digestive tract.
Okay, so it goes straight in.
Yes, it is highly effective and acts very quickly. It's often utilized in late-stage pregnancy when a mother is dangerously anemic and we need to raise her hemoglobin levels rapidly before the massive blood loss of delivery, or for patients with severe inflammatory bowel disease who can't tolerate pills.
The NHS protocols note a very specific and quite startling risk with IV iron, though: permanent skin staining.
Yes, it is a rare complication, but a very serious one aesthetically. If the IV needle slips or the vein wall ruptures and the liquid iron leaks out of the vein into the surrounding subcutaneous tissue, a medical event called extravasation, the heavy concentration of iron will permanently tattoo the skin, a dark brown or black color.
Oh, that sounds awful.
It looks like a massive permanent bruise. Because it's heavy metal deposition, it doesn't fade over time. This is why strict infusion protocols mandate a normal saline flush beforehand to ensure the vein is completely secure and require close, constant monitoring by the nursing staff during the infusion.
Good to know. If you were getting an iron infusion, keep your eyes glued to that IV site and let the nurse know immediately if it burns, stings, or swells even a little bit. Now, what about treating anemia of chronic disease, the padlocked warehouse?
As we firmly established earlier, throwing oral iron pills at ACD is useless and potentially dangerous. The primary gold standard treatment for anemia of chronic disease is to relentlessly treat the underlying disease that is causing the inflammation.
Treat the root cause.
Exactly. If you control the patient's rheumatoid arthritis with modern immunosuppressants or successfully treat the chronic tuberculosis infection, the inflammatory cytokine levels will drop. When the cytokines drop, the liver stops producing hepcidin. The padlock comes off the warehouse door naturally, the stored iron floods back into the bloodstream, and the anemia resolves itself without a single iron pill.
But what if it's life-threatening?
In very severe, life-threatening cases where the patient's heart is failing from hypoxia, doctors might use erythropoiesis stimulating agents, synthetic EPO injections, to artificially whip the bone marrow factory into producing cells despite the inflammation, or resort to direct whole blood transfusions. But treating the root cause is always paramount.
Okay, let's equip our listeners for their next doctor's visit. If someone is experiencing these symptoms, when should they absolutely bypass the dietary swaps and call a doctor immediately?
You must seek emergency medical care if you experience extreme, debilitating fatigue combined with a fast, irregular heartbeat, shortness of breath at rest, or severe chest pain. That combination indicates that your cardiovascular system is actively failing to compensate for the hypoxia. Your heart muscle is starving for oxygen.
That's the ER warning.
Yes. Also, if you notice that you are passing black tarry stools and you are not currently taking an iron supplement or Pepto-Bismol, that is a medical emergency. It strongly indicates you are actively bleeding into your upper gastrointestinal tract, like from a ruptured ulcer.
And if it's not an emergency but a standard consultation because you're just feeling relentlessly fatigued, what is the checklist of questions the listener should actively ask their doctor?
You need to be your own health advocate. First, ask explicitly. Can we ensure we are ordering a full iron panel that includes a ferritin test, not just a basic complete blood count? You need to know definitively if your warehouse is empty or padlocked.
Okay, that's number one.
Second, ask, could any of my current daily medications be contributing to this? Specifically mention if you take daily NSAIDs like ibuprofen for joint pain, or if you take strong antacids. And third, especially if you are following a strict vegetarian or vegan diet, or if you are planning to become pregnant, ask, should we also check my B12 and folate levels?
Why B12 and folate?
Because a severe deficiency in those vitamins causes an entirely different structural type of anemia, macrocytic anemia, where the bone marrow factory builds giant, bloated, completely dysfunctional delivery trucks.
So to summarize this immense biological puzzle, anemia is a symptom. Is an alarm bell, a check engine light, not a root cause. You must investigate the why. Understanding the profound difference between a raw material shortage and iron deficiency anemia and a padlocked, cytokine sabotaged factory and anemia of chronic disease empowers you to actually seek the right treatment, rather than just blindly throwing heavy metal supplements at a locked door and hoping for the best.
Exactly. Don't throw pills at a locked door.
But as we wrap up this deep dive, I want to leave you, the listener, with a final, slightly provocative thought to mull over. Something that really struck me when reviewing the deeper clinical research sources regarding inflammation.
Oh, the nutritional immunity aspect.
Yes. We spent a lot of time detailing how, in anemia of chronic disease, the body's immune system uses cytokines and hepcidin to actively hide iron away in the tissues. It pulls it out of the bloodstream and locks it in the liver. Now, why would human evolution design such a seemingly self-destructive system? Well, we know from microbiology that many invading bacteria, deadly pathogens, and even rapidly dividing tumor cells absolutely rely on iron to grow, replicate, and spread. Iron is an essential life-sustaining nutrient for them just as much as it is for us.
It is the absolute fuel for their replication. They cannot survive without it.
Right. So this raises a profound question. Is anemia of chronic disease actually an evolutionary defense mechanism? Is your body intentionally making you anemic, intentionally sacrificing your daily energy levels to literally starve out an infection or a tumor? Is it locking the iron in the warehouse so the invaders can't use it to kill you? This concept is called nutritional immunity. And if that is true, if we just blindly look at a blood test, see low iron in the blood, and artificially pump a chronically ill patient full of IV iron to fix their anemia, could we accidentally be feeding the very disease the immune system is desperately trying to starve?
It is one of the most profound, hotly debated questions in modern hematology and infectious disease. By intervening with aggressive iron therapy in a chronically ill patient, are we helping the patient recover their energy, or are we inadvertently arming the enemy they're trying to fight?
It makes you look at that murky, muddy diagnostic water in a whole new, deeply respectful light. Sometimes the human body breaks its own supply chain for a very good ancient reason, something to think about until the next deep dive.